Thank you for giving me an opportunity to talk in this August gathering. My case was this, that it was a 78-year-old lady with shortness of breath, palpitation, SpO2 86%, irregular pulse 120 per minute, and BP 176 by 104. Since I work in an emergency setup in an ICCU and I'm mostly in charge of it when I do work, I see a constellation of cases like this. And I want to share with you a number of cases. And please pardon me because these cases were all seen in a real-time mode in the emergency. And so I don't have an archived view of all these. All the views will be fairly visible to you, and they are mostly taken on a photograph mode on my mobile phone or my colleague's mobile phone. And let me just go into the topic, and I'll be talking when I show you the slides. The similar presentation we had was like this: an 81-year-old lady panting for breath as she entered the echo room. The pulse was 114, blood pressure 186 by 92, saturation was 93, suffering for quite some time with severe similar exacerbations during the change of seasons, she said. And the pain chest was often and on, even when moving to the toilet. And these were the views. See, the patient was in atrial fibrillation. They had a dilated left atrium. There was a chink of pleural effusion. The pulmonary artery was almost normal. The contraction was not that bad. And here you can see the pulmonary artery color flow was also okay. Only we saw there was a tricuspid regurgitation with pulmonary arterial hypertension. We thought this was a case of acute exacerbation of COPD, and we referred this patient to the chest counterparts. Why I say this is a challenge? Because frequently these patients referred from the general emergency room to the cardiology on call, do not have a chest X-ray, do not have an ECG done, as they say the patient was too sick. No previous records, and the party said that they rushed a sick patient to the ER and they didn't have time to bring the records. And the cardiology on call is surrounded by a group of anxious patients who practically don't know anything about the history of the patient, but they expect a miracle from the cardiology on call. And similar case was this 75-year-old lady, only 34 kgs weight, malnutrition severe. The patient was so orthopnic, she couldn't lie down. Bilateral pedal edema was there, and the patient might be having a hypoproteic edema. Pulse AF was 132, BP was on the right on the higher side, and SpO2 was pretty low. And this was how we took. And if you can understand from the background noise that the party was so anxious that you wanted the patient to lie down, which the patient could not. The cardiac contraction was more or less okay. We had some amount of tricuspid regurgitation. Both atria were dilated, and see we wanted to open up the IVC. The IVC was also dilated. And if you see the cardiac contraction was more or less normal. This patient also had a respiratory problem, and the patient had multiple medical problems, was referred back to the medicine department. This acutely ill octogenarian male patient was very dyspneic and acute shortness of breath, on really tossing on his bed. Had hypertensive response. It was known case of IHD, was treated for myocardial infarction 8 months back, at extreme tachycardia and tachypnea. And see, this was the monitor view of the patient. See, the pulse rate was very high, saturation was low, the tachypnea was there. And see, there was initial hypertensive response which had come down within 30-40 minutes. This was the echo. The patient has also scarred IVS, and see the dilated LV with almost barely contracting, only 20 to 25% EF, yet the patient had a hypertensive response. The patient was initially treated with decongestion and nitroglycerin. When the pressure started falling, we had to put the patient back on ionodrops. In no time, within 2 hours or so, the patient quietened down, but became real bad and to be put to the ventilator. And the patient is still fighting on the ventilator. We don't think we'll be able to salvage this patient. And this was the echo. You can have a look at the echo and see how poor the ventricular function was. We wanted to see whether this patient has the instant thrombosis or not, but the patient is not that well that it can be wheeled down to the cath. Late presentation in a case of 62-year-old female patient had palpitation, shortness of breath for the last 2 months. Pulse was 126, blood pressure was almost normal, respiration was a bit hurried, SpO2 was low, and we heard a mitral mid-diastolic murmur and bilateral basal grapes. We thought we are dealing with a case of mitral stenosis, and see what the echo was. The echo showed there was a mitral stenosis of the degenerative valve, and the contraction was poor. There was a chink of pericardial effusion, and there was something in the posterior aspect of the left atrium. And when we opened up the 4-chamber view, it was a huge clot, almost occupying 2/3 of the left atrium. The patient, of course, had a mitral stenosis and a small mitral regard, had a pulmonary hypertension that was seen in the tricuspid regurg with pulmonary hypertension, and the contraction was not that good with a chink of fluid, because probably the patient had high ventricular rate. And we had another photograph. This was a long time back photograph of mine, which I never thought I'd be present. This was a huge clot sitting in the LA, almost obliterating the LA. We had to operate this patient in the CTVS department. It was done, and the patient was doing well after that. Pericardial effusion was seen in this male patient, admitted 4 months back elsewhere, was diagnosed to be a DCM but did not have pericardial effusion. Later seen in Jayadeva Hospital, they walked the patient up and they found it was a case of idiopathic DCM. The patient was admitted with pain chest to us and shortness of breath. The pulse was 109, blood pressure of 86/64, and SpO2 was 93%. We sent blood for creatinine, and the creatinine was high, potassium was not that high. And see, we sent the blood later, but see what we had seen in the echo. The echo showed this. The patient has a huge pericardial effusion, and the contraction of the systolic contraction of the left ventricle was not that good. So, and there was diastolic collapse in the free wall of the RV. The patient was having some amount of pericardial tamponade as well, and see the IVC was also quite dilated. We did a pericardiosynthesis on this patient, and the patient was referred for nephrology consultation. This young male patient, orthopnic anxious, was referred from the CTVS to review as he was on treatment for and waiting surgery for peripheral vascular disease. The pulse was high, the BP was high. There was no cyanosis, but had a puffy face, JVP looked full, and bilateral little pitting edema was there. We had just a sinus tachycardia on the ECG. We thought we are dealing with a case of thromboembolism of the pulmonary arteries, and we started doing the echo, and we saw that RV was not that dilated. The LV was contracting well. There was a chink of pericardial effusion, mostly pocketed posteriorly. And we opened up the pulmonary artery. The primary artery was all right. Since the patient could not lie down properly, we had to do a subcostal view. And we took the subcostal probe. For the IVC, we saw there was a huge pleural effusion on the right side, and the X-ray was done immediately, and we found it was a case of pleural effusion. We sent this patient back to the chest department, and they did the rest of it. This frail orthopnic scoliotic male patient came with a heart rate of 56 and a low blood pressure. We thought we are dealing with a case of CAHP, conscious cooperative, and he had a history of taking ATT on 2 occasions the last 6 years back. And when we saw the echo was like this. A hugely dilated right side of the heart, the left ventricle had been subjected to a chink, and there was significant regurgitation of the tricuspid valve. We thought we are dealing with a case of chronic pulmonary, or maybe a case of chronic pulmonary thromboembolism. We wanted the patient to go for a chest CT and then go to the chest department. This was a very unfortunate case of a 32-year-old, 4 months postpartum female at high fever for 20 days. Cough and dyspneic. The pulse was 150 per minute. The blood pressure was more or less on the lower side, and was tachypneic. SpO2 was low. We thought we are dealing with a case of postpartum cardiomyopathy, but when we did an echo, this was the echo. We saw a vegetation on the undersurface of the right side of the heart. We thought we are dealing with a case of multiple thromboembolic episodes of these patients. they wanted to open up the pulmonary artery. The pulmonary artery looked this way, and there was another part of the vegetation. So initially we thought that it was another vegetation, but we found out it was the same vegetation that was popping almost the tip of the pulmonary artery. This patient was thought to have a infective endocarditis, and the patient was later on subjected to the CMR to find out whether we are dealing with a case of infective endocarditis or dealing with a case of clot. Ultimately, it was infective endocarditis. The patient was operated in the department of CTVS. They took out the endocardial mass, but the patient could not be salvaged because we were perhaps the patient was too bad by that time. This is a case of dilated right ventricle in a male patient presented with VT. So we did a cardioversion, and later when we did the echo, I'm very sorry for the quality of pictures, but it's an interesting case, so I'm keeping it. See, this was the plaques view, and see the RV was so hugely dilated. This was a case of ARVD with a huge clot, and you can see the clot in the right ventricle. This right ventricular clot must have, during the cardioversion, gone to the pulmonary artery, and the patient landed up on the ventilator only within 1 hour. We had a very tough time to bring the patient out, but ultimately the patient had succumbed to intense sepsis. So as I was telling you, it should be a constellation of cases when they are present to our emergency department. It may be a case of acute myocardial infarction, it may be a case of AE COPD, heart failure acute and chronic, rheumatic valvular disease with CHF, AF with fast ventricular rate, IHD post recanalization, maybe having an ISR or maybe a fresh infarct, pericardial tamponade, or a host of medical emergencies may also come, like hypothyroid, palpitation, anxiety, SOB, massive pleural effusion, massive with SOB, chronic cor pulmonis, CKD, even chronic pulmonary thromboembolism. So our take-home message is, not all patients referred to cardiology ER should be necessarily a cardiac patient, but the echo assessment in the ER may be important guide for medical cases for urgent and proper management. A favorable outcome for the patient is all we are looking out for and should be the goal of therapeutic management. I'll end up with the last case. This was an Ola driver, 65-year-old male patient, complained of chest pain and palpitation and came to the emergency room at 4:30 a.m. in the morning. Had an history of PTC had done 5 years back in Dubai, and he said he had similar attacks in Dubai for which he used to go to the hospital, and they used to see him for that. He doesn't have any past record because he came right when he was on his duty. He was a non-smoker, non-diabetic, taking clopidogrel, atorvastatin, and metoprolol succinate. The ECG showed a QS between V1 and V4 with a slightly raised AC segment in these leads. The QRS was 110. It was a sinus rhythm. Qualitative TROP-T was negative. So we took the patient for an echo. The echo showed this. If you can have a look at this, there was a hypokinetic anterior part of the interventricular septum, and there was scarring on that region. But the contraction was not that bad. He was having ejection fraction of around 45 to 50%. There was no significant MR. There was no significant other valvular lesions. We said that the patient was all right, and the patient also, after the echo being done, was so happy that he went back driving his own vehicle. I kept this case only to show you that on mere echocardiographic assessment and reassuring the patient has also done its work in our case. So ultimate patient outcome is our motto, and for that we have done everything in our emergency echo room. Thank you for your patient hearing, and these are the two more echoes that we have. And this was the case with the patient presented with palpitation, had a previous history of left atrial myxoma, operated 10 years back, had right atrial myxoma this time, and this patient was also operated and was doing nice. This was another echo that I was shared from Dr. Abhijit Viswas kindly, and this was an interesting looking left atrial clot in a case of rheumatic heart disease. Thank you.